Welcome, everyone, to Sonata Insights Live. I am Tara Murphy, Senior Director of Global Marketing and Advocacy for Gynesonics. Sonata Insights Live is a program that we have launched at Gynesonics to spark conversation about fibroids, the symptoms of fibroids, and talk to you about your treatment options. During these episodes, you will hear from our guest physicians, patients, and advocates as they share stories and educate our audience about fibroids. Today, we are very excited to have Dr. Kolev from Mount Sinai in New York City joining us today. Welcome, Dr. Kolev.
Thank you so much. It's a pleasure being here.
So we are going to just start from the beginning and the very basics. If you could talk to us a little bit about what are uterine fibroids.
Okay, great. Let's start from the beginning.
Yeah.
So basically, uterine fibroids are growths within the uterine wall that are actually comprised of muscular tissue. Most of the time, they're benign growths, but the problem is that depending on the location and the size within the actual uterus, they can start to cause certain symptomatology.
And what kind of symptoms do you see from your patients when they come in, whether they know that they have fibroids or not? What are those symptoms that are kind of triggering them to want to come to see you for a consultation?
That's a great question. So generally speaking, when we look at the symptoms from fibroids, we break it down into two different components. One of the things that fibroids can do is they can cause abnormal bleeding. So they can cause very heavy periods, painful periods, bleeding sometimes between periods. So just a lot of heavy bleeding. So that's when we look at the bleeding aspect of the fibroids. And then also, depending on how big they get and the exact location within the uterus, they can start to cause what we call bulk symptoms. So when patients complain of bulk symptoms, some of the things they complain of are pelvic pain, really painful periods, back pain. They can start to interfere with some of the other organ processes in the body, like they can start to push on the bladder. So patients may feel a constant urge to urinate or frequency. So, some patients may experience one or more aspects of fibroids, and some patients may experience both of those aspects. And of course, to different degrees, depending on the location and type of fibroid.
And are there different risk factors that make you more likely to have fibroids, or is it tied to genetics in any way, or is there anything that you see as far as a pattern as to who gets fibroids or who is more likely to suffer from fibroids?
Yeah, we do actually see a genetic component. So a lot of patients will report that their mother or their aunt or someone in the family has suffered from fibroids. We also see a correlation with estrogen. So fibroids are estrogen driven. So a lot of patients who are still very much in their years where estrogen is pretty dominant suffer more, whereas postmenopausal patients, the symptoms start to decrease and the fibroids don't necessarily grow as much. Tied in with that would be parity. So, the number of children you have decreases the risk factors for fibroids. Earlier age of menarche, which is when you get your period, may increase the rate, the incidence of fibroids. And then race also plays a factor. So we find that a lot of African American women suffer the most actually from fibroids.
And I think it's interesting, we hear a lot that women say that they, as you said, their aunt had fibroids, their grandmother had fibroids, their mother had fibroids, but they always thought that heavy bleeding and the symptoms that they were having were normal because they saw all of them kind of just going through that their whole life. So they didn't really understand that was something that wasn't actually normal.
Of course, and this is Tara, sorry to interrupt, but this is something I see all the time with my patients, is that I don't think as young women, there may be an unrealistic expectation of what your period should be. So I have patients who suffer for many, many years and have these painful periods to the point where some of them are even severely anemic from them because the bleeding is so heavy. And the response is, I thought it was normal. So, it's sad, and that's why we're here to really advocate for our patients to speak up.
Yes, exactly. That's why it's so important that I think it's kind of the each one teach one mentality where we're trying to
Yes.
spread the word and educate about what is or isn't normal. And, it's not normal to continue to bleed through your clothes or have to take a change of clothes when you're going to work and those types of things. So we definitely appreciate you being here and educating women about these things.
Of course,
Uh,
it's my pleasure.
so, say a woman has these symptoms. She maybe started to read or know about fibroids or not. She just knows that what's happening to her isn't necessarily normal. How do you actually get diagnosed with having fibroids?
So typically it takes, a few steps to get to the actual diagnosis. First, we start off with the patient's history, and we ask them about their menstrual history, etc. And then we do some evaluation. So one thing that I always will check is some blood work. See, maybe is she anemic? How badly is she anemic? Where are we at with the bleeding situation? And then I typically do imaging. So the first thing we'll start off with is a transvaginal ultrasound, which will help to evaluate the uterus and the fibroids. But then I usually follow that up with an MRI. And the reason for that is the MRI gives me a lot more information about the fibroids. Because, like I alluded to earlier, fibroids can be in different areas of the uterus. If they're within the cavity, they may be small, but they may cause more bleeding. If they're on the outside, they may cause less bleeding, they may cause more belt symptoms. This is just a generalization. So, depending on the exact location and how big they are and where they are, will tailor our management towards the fibroids. And that's why imaging and MRI studies can be very, very helpful to get us a much better idea for that. And obviously the physical exam too. So when I see the patients in the office, not only will I get their history, but I'll actually do a physical exam to appreciate, where and what the fibroids are.
And is it common for women to have more than one fibroid that are in different locations and different sizes?
Absolutely. I've seen very, very different presentations of fibroids. Some may have one big one, some may have one small, some may have multiple. So it's very common for that to be different between females.
And so, what we talk about a lot when we do these events is how important it is to find a physician like you that is talking to women about all of their different treatment options because every woman's case of fibroids really is truly different. There's not a single path that's really right for every single woman. So, can you talk a little bit about if we start with the least invasive type of treatment option? What is that a woman would start with, like a medical management type of treatment?
Exactly. So really the medical management for fibroids is going to really be targeting the bleeding. So there are some medications, for example, Lupron, that may help to shrink the fibroids, but once you stop the medication, they'll come back. So it's more temporizing. So really, when you look at medical management, you're looking at targeting the bleeding aspect. So there's certain things like hormonal management, like your combined estrogen progesterone, your pill, your patch, your ring. There's also stuff like the progesterone only, like, for example, progesterone IUD. And then there's other newer medications, Orion, that helps to basically as an anti-estrogen with add back. So there's a bunch of different medical managements that we can give. There's some medications that are non-hormonal that you give to women just at the time of their periods to help to decrease the flow. And that's basically managing the bleeding aspect of it. Now, if the fibroids are small and they're able to be managed that way, we can continue that. But if the fibroids are larger, or if they're in a location that, kind of, we can kind of get away with that for a while, but it may not be something permanent. And again, like you said, it's very patient specific.
And we have heard from women at times that when they've gone on medical management, that they thought that they stopped their fibroids from growing, but then they had come to find out, their fibroids were actually continuing to grow, but because their symptoms had settled down a lot, they assumed that their fibroids had stopped growing or started to decrease in size as well, but then came to find out they actually had grown larger. Can you talk a little bit about what type of medication or what that scenario may be for a woman?
Well, a lot of the times, especially if the fibroids are small or they're like within the cavity, initially the symptoms may be controlled. So they don't, you think that the fibroids are actually shrinking. But like I said before, the medication is not going to permanently decrease them. Lupron, which is an anti-estrogen, and Orion may help to decrease them, but then when you stop them, when the estrogen comes back, they may come back. So I think that's a little bit about what patients may experience, as well as when we start you on, medical management, it may help with the bleeding, but that's not getting rid of the fibroid.
That's a great explanation because I think that's a very common thought that we hear about a lot from women. So, say medical management doesn't work, maybe they go on to something like a myomectomy. Can you talk a little bit about what a myomectomy is?
Absolutely. So then we start to go, before that, we can talk about, there's more procedural stuff, right? So before we talk about actual surgery, one thing is called the uterine artery embolization, and that's more procedural. And that's where it happens in the radiology suite, and you block the blood supply to the uterus. Now that can help to decrease the fibroids in their actual size, and that can help with the bleeding. But we don't typically do these sort of procedures on reproductive age women because of, wanting future pregnancies and issues with the placenta, in the future. So we just don't typically recommend that. So if we have a patient now going for surgery, one procedure that you spoke about is what's called a myomectomy. So basically a myomectomy is removing the fibroid. And there's different ways that we can do that depending, again, on size and location. So maybe what's called hysteroscopic, which is where we go in through the cervix and remove it that way. But that's only for a very specific type of fibroid. Then the other way would be more of an abdominal approach, either with laparoscopy or robotic assisted laparoscopy or through an open incision. And that's where you actually remove the fibroid and then have to repair the uterus.
And what's the recovery look like for something like that?
It really depends on what type. A hysteroscopic procedure, the recovery is minimal. Whereas if you had to do a big open procedure, typically the recovery can be up to 6 weeks. And then with that, you would need to delay pregnancy for at least 4 to 6 months. And a lot of the times, if these fibroids require if there are a lot of fibroids and they're big and they require a lot of repair of the uterus, a lot of the times those patients are recommended to have a cesarean section in the future.
Oh. So then what's next? If you go more to the more invasive,
obviously patients who are done with childbearing and who have suffered from fibroids, we would recommend, removing the uterus, which is called the hysterectomy. Depending on the patient's age, we may or may not recommend removing the ovaries. So a lot of the times if they're younger, they can keep their ovaries. Normally when we do hysterectomies, we remove the tubes too, because studies have shown it decreases the risk of ovarian cancer, obviously, in the tubes, and you don't need them. And basically that would be more of what we call the definitive approach to management of fibroids.
And a common question that we get, you mentioned removing or not removing the ovaries. Can you talk a little bit about the misconception of all hysterectomies? If you get a hysterectomy, you go into menopause.
Yes. Common misconception. And then there's also, and I also often get this, right? So you can when you do a hysterectomy, you can either leave the ovaries or take them. And then the same thing with the cervix. So when we remove a hysterectomy and we actually remove the cervix with it, we call that a total hysterectomy. It's got nothing to do with the ovaries. It's got to do with whether we take the cervix or not. If you leave the cervix, it's called the supracervical hysterectomy. Again, nothing to do with the ovaries. So common statement I get with patients who are like done, they're like, but I'm not ready to go into menopause. But if you're in your mid-40s and I'm taking out your uterus, I promise you I'm not going to put you into a surgical menopause. So the ovaries are the component of the female anatomy that produces estrogen, and that's what drives, whether or not you go into menopause or not. So you can absolutely have definitive management, remove the uterus, and still have all of your hormones.
And what's the recovery look like with a hysterectomy?
So it depends if we do the procedure laparoscopic. If we do the procedure laparoscopic, my patients typically go home on the same day. They need at least 2 to 4 weeks off of work and about 6 weeks before anything strenuous. If we do an open procedure, the recovery is a little longer. I like to keep them in the hospital, at least one night to evaluate and monitor them. And then, about 6 weeks before they can, really do anything very strenuous. And again, everybody's different. So I notice some patients recover faster than others. Everybody's a little bit different. And the degree of complexity of the surgery will also drive the recovery time.
And what would you say to women that would go to a consultation with a physician out there that only said you have one treatment option and doesn't really hear the woman talking about what she's desiring as far as like her long-term plan or interest of getting information about other procedures? What advice would you give to those patients?
I think patients need to be offered all of their options. Physicians can guide patients depending on the clinical situation and what they, what would probably work better for them. But I think patients should be offered all of their options in order to make an informed decision, because there isn't only one type of treatment. Maybe some things in some situations may be better than others, but I think that, a patient-physician relationship needs to go both ways. So both, the doctor and the patient need to kind of listen to each other and come up with a mutual agreement on the best option.
Absolutely. Thank you for that. That's very good advice for them. So we are here to talk about the Sonata treatment. So the Sonata treatment, as you all watching know, is a treatment that was created by Gynesonics. So we did want to talk about that with Dr. Kolev today. So if you could just talk a little bit about how do you explain the Sonata treatment to your patients and what it is?
So Sonata is a treatment that uses radio frequency ablation. So essentially what we do is there's most fibroids we can target. There's certain exceptions that we can't. And basically what it is it's an ultrasound. So like when you get a transvaginal ultrasound, it uses an ultrasound to go in through the vagina and through the cervix. So that's what's called transcervical. We go in through the cervix and evaluate the fibroids with the ultrasound from the inside of the uterus. And then we're able to isolate these fibroids and put certain probes actually into the fibroids to emit radio frequency. And what that does is it basically starts to work to kill the fibroid and basically break it down using radio frequency. So what we found with that is that patient symptoms and bleeding significantly decrease. And over time, the fibroids do get smaller. Now, they're never going to go away completely from it, but they do actually get smaller and the bleeding does improve dramatically. Now, what's nice about this is that you may have a patient who's sort of in the middle of like, could you remove this surgically through the vagina, or maybe not, it may be too big. So then am I going to have to go in and do a big abdominal surgery? So this is a great procedure to target these sort of fibroids and other fibroids as well. And what's nice is it's completely incisionless and very minimally invasive. So I do give the patients a heads up that we, may take up to 3 months to actually start to see significant differences in their bleeding, but it is definitely a great option. Now, it's obviously patient dependent, not an option for everybody, and it depends on your symptoms, but it is a great new tool that we have, and patients get excellent results.
And what do you see from your patients as far as what does the day of the procedure, after having the procedure, how are they feeling? What does their recovery look like after having the Sonata treatment?
So Sonata is an outpatient procedure. So I typically perform the procedures in my surgical outpatient center. The patients receive a very light anesthesia, almost equivalent to colonoscopy. Um, they come in that morning, they get prepped for surgery. Depending on how many fibroids we target, every target range can range from like maybe 3 to 7 minutes. It really varies depending on the size and the location, but we're able to do multiple targets and we can't actually address more than one fibroid. Typically, the procedure doesn't last more than an hour, sometimes less, again, depending on what we're dealing with. After the procedure, they go to the recovery room. They typically stay in the recovery room for about an hour to wake up, give them some crackers, they use the restroom, and they get to go home the same day. Some of the, sometimes after the procedure, maybe feeling a little bit groggy, your body's undergone anesthesia, it's a little tired. Some patients get some cramping, especially in the first day or two, completely normal, as they would with a DNC or a hysteroscopy or any procedure like that. And they may have some, irregular spotting and stuff initially for the first few days, but that typically resolves and they can go back to their regular activities the next day. We just counsel them nothing in the vagina for 2 weeks, similar to as if you were to have a DNC.
And what have your patients told you, as far as how are they doing after they've had Sonata in the weeks and months following?
I've had a great response. My patients are really happy. I've seen decrease in bleeding, decrease in some of the pelvic pressure that they were having from the fibroids. Just very very good response from them. Some of my patients will get their periods, but it's not the same. I have done follow-up imaging, which has been very rewarding to see, fibroids breaking down on MRIs. So we've had really good data.
That's awesome. So we've talked about what are fibroids, what are the symptoms of fibroids, how do you know if you have fibroids, what are all of the different treatment options that are out there, including Sonata, and you've given some very good advice about that patient-physician relationship and how it should be a shared experience. Is there anything else that you'd like to share with our audience, just about giving them that information that they need to feel empowered as they go into a doctor appointment or a consultation, or if they feel like they may be having symptoms of fibroids?
Absolutely. I think that patients mustn't be afraid to speak up. Even if you have an evaluation and you don't have fibroids, maybe there's something else. Fibroids are not the only thing that are going to cause heavy, painful period. There are others. There's adenomyosis. There's other things. So if you are suffering as a patient, you do not need to suffer in silence, and have it evaluated and have it worked up and really understand all of your options. And I always tell patients, go speak to somebody else, get a second opinion. This is your body, and you need to make sure that you understand all of your options and what the best treatment is for you. And it may be Sonata, it may be a hysterectomy. It really varies, and you should take the time to speak to your doctor and really feel comfortable with that.
Thank you. We are very lucky as women to have a physician like you out there to give that kind of information and advice. We just had a question come in that was, what are the risks with Sonata?
So Sonata is any surgical procedure, any bleeding, infection, damage to the surrounding organs, very, very minimal. And one thing that's great about Sonata is when you actually use the device, there is a safety zone. So when you start using radio frequency, you don't want to damage anything outside of the target area, right? And on the outside of the uterus is what we call serosa, and past the uterus is all other things you don't want to get involved with: bowel, bladder. And the great thing about this knot is that when you do it on the screen, you're able to set what's called the ablation zone, which is where you're actually using the radio frequency. And then you're able to set a safety zone. And that makes, especially as a physician, us feel very confident in the fact that we're not going to be damaging other organs. So the risk, therefore, is minimal, just occurs with basic surgical risks that are involved.
Thank you. Um, So for all of you out there, if you would like to find a physician that is interested in giving a consultation for Sonata, you can go to our website, which is sonatatreatment.com. And if you would like to find Dr. Kolev in New York City, she is listed on there, and we will be happy to direct you to her. There's also information on there to find in Gynesonics. Our Sonata nurse advocate, Teresa, can help to direct you to Dr. Kolev as well. So thank you very much, Dr. Kolev, for all of your
Of
information
course. Thank you
today.
so much for having me.
As I said, we are very lucky as women to have you on our side as a physician to talk about all treatment options, and really just to help educate us and find out what is ailing us when something isn't
Yeah.
normal. So thank you for that.
Well, thank you so much for having me. I appreciate being able to share with you guys and being here for you.
Thank you. So join us for our next episode. Look online. We will be posting our next dates with our next guests, always at 3 p.m. Pacific, 6 p.m. Eastern. And be sure to go to sonatatreatment.com to be connected with Dr. Kolev, or reach out to our nurse advocate and we will connect you with her office directly. As well, if you have any other questions for her specifically, we could help to get you set up with her over email. So thank you all very much for joining us today. And thank you again, Dr. Kolev. Always a pleasure to have
Thank
you
you.
with us.